So today in the series of Docplexus KOL interviews, we have Dr. Sinukumar Bhaskaran, who is an orthopedic and joint replacement surgeon at Columbia Asia Hospital, Pune. So thank you so much for being with us today. So why is the Orthopedic Society so worried about infections?
You see, Shreyas, orthopedic procedures have mainly metallic implants involved in them, either fixing the bones or replacing certain areas of bones. And the organisms that infect our implants tend to secrete a layer called as biofilm around these infected implants. And what this biofilm does is it prevents antibiotics from getting to that site where the organisms are exactly. So you cannot treat them like normal infections, like giving a course of antibiotics or washing up the joint. So unfortunately, if an orthopedic implant is infected, the whole implant needs to come out, which is not a good scenario for the surgeon as well as for the patient. So we are more obsessed with preventing infections rather than having to deal with them at a later stage.
So as you said that you have to remove the complete implant if there is an infection on it. So is infection an end to the road of artificial implants?
Not really. What we with our newer techniques, we do have methods by which we can get back the patient onto a normal kind of situation. What we need to do, like I mentioned before, the implant needs to come out. Then we put in something called as an antibiotic spacer, loaded spacer, for a few weeks, and then we have to go in and then put in a final implant. It's called as a revision implant. This is a two-stage procedure involving almost 2 months for the patient. So even though there is a positive outcome for the patient, it does involve a lot of, we can say, physical, emotional, and financial, of course, financial burden on the patient. So definitely preventing infections is better.
Sir, as you said that prevention is definitely better than cure. So how can doctors prevent infection, especially when it is related to joint replacements?
Again, for that we need to understand that infection is not just a two-point process where an organism is getting into a wound and multiplying there. It's more of a complex interplay between three factors. That is the host, which is the patient, the organism, of course, and thirdly the environment, that is the hospital, the OT, and the wards, etc. So just by giving antibiotics, we are not preventing infection. So we need to take care of a lot of other factors by which we can prevent infection. So it actually starts, for me, infection prevention starts the moment the patient walks into my OPD office. So the patient evaluation starts at that point, like if he's got diabetes, if he's a patient with rheumatoid arthritis on steroids, if he's a high-risk patient for MRSA infections, if he's got some other focus of infections like urinary tract or ear, nose, throat infections. So all these need to be optimized before I take them up for surgery. So they are investigated and accordingly again further checked by a physician before we actually plan out the date for surgery. So that is the preoperative part. And once the patient is admitted, we need to prepare the patient so as the bacterial load that the patient sheds in the operation theatre is brought to a minimum. We do that by doing something called as a preoperative chlorhexidine baths. So that is usually done about 12 hours before the period of surgery, about 2 hours before the period of surgery. It's done twice before the patient is taken up for surgery. I really do not advocate shaving the surgical site of the patient. There is very clear studies that indicate that shaving the patient on the night before surgery can in fact lead to further infections. Once the patient is in your theatre, we need to realize that the maximum amount of organisms that is there in your operating room is shed from the skin of the patient as well as the operating team, that is the surgeon and his team. And the other bacteria is the bacteria that is present within the operating room environment. So all the techniques and modalities go to preventing or reducing this bacterial load. Of course, patient preparation, again, that which happens in the operation theatre, we like to use chlorhexidine-based solutions to bring down the bacterial load. The operating team, washing up and preparing for surgeries, again, very important. Your gloving techniques, your draping techniques. As far as drapes are concerned, we are very big fans of using disposable drapes. The old, the cotton or the spun woven fiber used in drapes can again lead to a lot of shedding of bacteria and can cause infections. Besides the patient preparation and the surgeon getting prepared for the surgery, The OT environment is very important, where we have something called as laminar airflow systems, which maintain extremely low amount of bacterial counts within the operating room environment when we are performing the surgery. Then factors like handling the tissues while operating, we need to maintain a, if not very quick surgeries, but there should be a decent time in which you need to complete your surgeries, because very prolonged surgeries again can lead to increased rates of infection. So once the patient is operated and he is shifted out of OT, your infection prevention protocols are still continuing there, like how you handle the patient in the ward. You should be very careful with basic techniques of hand washing, hand scrubbing before you actually touch your patient. As far as dressings are concerned, I do not like to repeatedly handle the wound. I just do one dressing on the day after the surgery and the second dressing the time the patient is getting discharged. So again, these are basic. It's a very generalized guideline as to how we go into preventing infections, and it's not just that antibiotic dosage that we are giving for 4 or 5 days that is going to prevent infections. At Columbia Asia, we are very specific as far as antibiotic use is concerned. We just give a single day of antibiotics, one dose on the morning of the surgery, that is about within 60 minutes of the incision of the surgery, and depending on whether the patient is a single knee, that is a unilateral knee replacement, or a bilateral knee replacement, we either repeat one more dose if it is a unilateral knee replacement, and or we repeat 2 more doses if it is a bilateral knee replacement, which is of course all given within a period of 24 hours. So we just use about 24 hours of antibiotic prophylaxis, no matter what kind of patient, whether the patient is a diabetic or whether the patient is a rheumatoid. If he is optimized, he just gets 24 hours of antibiotics and not more than that. There is no other oral antibiotic followed up after that as well.
You were just talking about the prolonged use of antibiotics. So, what are the negative points that come while serving the prolonged use of antibiotics?
Using prolonged antibiotics, besides the obvious issues like it adds to the financial strain on the patient, there are the common side effects like abdominal discomfort, nausea, and diarrhea when you are using a long-standing course of antibiotics. More recently, microbiologists have come out with this theory that when you give antibiotics for a long period of time, or when you use a very high dose of antibiotics, what it does is it activates or agitates your normal bacterial flora on the skin, and this can then become more active and can lead to infection. So it is better to just give that short course of very moderate kind of antibiotic just to cover that period and get out of there. Besides these common problems, the greatest risk of prolonged use of antibiotics is the development of antibiotic resistance. Now, antibiotic resistance is not just a problem for the patient. The patient, of course, is going to develop antibiotic resistance, and later on he's going to have problems when he has some other infection. But antibiotic resistance, unfortunately, is disseminated through the community, and once you develop a resistant strain of bacteria, it is easily spread through the community, and that's how the community becomes resistant to a particular antibiotic. So, as doctors, we need to be very carefully using antibiotics. What is called as rational antibiotic usage has to be a very important part of our practice as well.
So you were talking about the antibiotic resistance that has developed in the community, and a doctor is a responsible person who should take care of it. So how can a doctor prevent the spread of antibiotic resistance in the community?
Yeah, for that we need to look back at the last century. If you realize the invention or the discovery of penicillin or the discovery of antibiotics as a whole was one of the most significant scientific breakthroughs in the last century. Since 1928, Alexander Fleming had gotten penicillin. Since then, we have had a lot of antibiotics at our disposal, and that's how we have brought in a lot of the infections under control. But at the same time, in 1940, when he got his Nobel Prize for penicillin, he had warned us that there is going to be a day when we are going to lose these antibiotics if we do not take care of them properly, and that's what we are exactly seeing today. The last antibiotic that was discovered was in 1987, and after that, it was just last year we have got one antibiotic, that is tioxobactam. So during this 20-year period, we've just got one antibiotic and one new antibiotic, and we have lost about 20 to 25 antibiotics to antibiotic resistance. During my days of education, basic medical training, we could use drugs like Ceftriaxone and ciprofloxacin, which was found to be very effective. And in today's day, we can very clearly see that these are antibiotics that do not work anymore. And the sole reason for that is indiscriminate use of antibiotics, giving very prolonged course of antibiotics, giving antibiotics where it is not needed. Just last year in India, WHO had collected data about pediatric deaths due to antibiotic resistance. So there were almost 58,000 children who had died due to purely antibiotic resistance. Now these are children who had your normal abdominal infections or respiratory infections, which could have been very well treated with your normal antibiotics. But antibiotic resistance was obviously a problem for them, and it gave them a very bad outcome. So what I want to say is that it's not just an orthopedician who's using another 3 doses of antibiotics or another 4 or 5 days of antibiotics which is leading to a situation like this. But there's an overall multifactorial cause why this is happening. But at the same time, we need to realize that specialists and orthopedicians that at some point when we use more than 4 or 5 days of antibiotics, we are contributing to this problem to some extent. Of course, there are other factors like indiscriminate use of antibiotics, over-the-counter prescriptions, abuse of antibiotics in the poultry industry. So all this can contribute to antibiotic resistance. But the onus is upon us as specialists or surgeons to take it up, to use minimal antibiotics, to use effective antibiotics, and so we can sort of pass it on as a message to the rest of the medical community, where we can try and take care of whatever antibiotics we have left with us.
So the antibiotic resistance theory which you have explained us was basically very informative. So we are glad that you at Columbia Asia use single shot antibiotics. So are there any other practices you practice apart from normal orthopedic and joint replacement?
Mainly we do joint replacements here at Columbia Asia. Besides the routine joint replacements, we have also introduced in quite a few cutting edge practices where we use something called as ISS technology, which is next generation of computerized knee replacement, wherein we just have to attach a few pods to the knee, and then that transmits data to an iPad that is kept outside, and then I get data feedback from that about my level of cuts that I need to take, at what angle I need to take. So it does 2 things mainly. One, obviously, it increases the accuracy of my cuts. It gives the patient a much better alignment. And secondly, and more importantly, what I can do in this is I do not have to drill bones as I do while using a normal instrumentation. One of the biggest risk factors while doing a knee replacement is when you're drilling into your thigh bone or into the femoral bone, and that can lead to something called as fat embolism, and that is a bit risky for the patient. So that is completely avoided when I'm using ISS knee replacement.
So like you said that while using the ISS knee, you also make use of your iPad, which gives you a better understanding of cutting edges. So what difference did you notice from shifting over from a normal joint replacement to ISS knee?
It was a stage-by-stage thing. From a normal knee replacement, we went to something called as navigation or a computer navigation knee replacement, which was there. But as you can see in your day-to-day activities, I mean, when we started off with the PC, it used to be a big box that was right in front of us. Similarly, in the operation theaters as well, we had a very big trolley with a big box placed on top of it, with wires passing from the OT table to the box, and that did get in your way. We're not sure whether it led to increased infection, but that of course got in the way of performing surgeries. And like in today's world, we are using iPads and much sleeker forms of PCs. Similarly, so we have a much sleeker variant of the computer, which is just an iPad. So the advantage it gives me is mainly it reduces my OT congestion. I have a lesser amount of space taken up by the machine. And definitely the freedom of movement is much more. There are no wires. It is a completely wireless technology, and of course the accuracy has improved with the software as well.
So we have a couple of questions from the members of Docplexus who would like to know a few things from you regarding the single dose antibiotic as well as the knee replacement. So Priya, in our previous conversation, we were talking about use of antibiotic for 5 to 7 days. How does single shot antibiotic help in knee replacement?
For that, we need to understand the difference between prophylactic antibiotic and therapeutic antibiotic.
Okay.
So prophylactic antibiotic is to prevent infection. When I'm doing a procedure like a knee replacement, the patient is not infected. What I'm doing is I'm trying to prevent infection there. So, and the maximum chance for the patient to develop infection is when we are taking an incision of the patient. So it's exactly that 1 hour prior or within that 1 hour before that the patient should receive that single dose of antibiotic. You could of course repeat another dose or maybe another dose, that is maybe maximum 24 hours. But beyond that, there are enough studies, enough literature in today's world which has shown that giving 5 to 7 days of antibiotics does not have any added advantage as compared to just giving 24 hours of antibiotic. So single dose or the 24-hour antibiotic protocol definitely can work in a clean surgery like the knee replacement.
So you were saying about the use of single dose antibiotic. So this goes with all the patient or is it patient specific?
If you're talking about all the patients, or like all types of patients with additional comorbidities like diabetes or rheumatoids, of course we do use them in all types of patients, provided that the diabetes is under control, the rheumatoid is being well optimized, the steroid doses have been under control. So we have not changed our protocol. The last 1 year at Columbia Asia, more than 150 joint replacements. I have just given this 24-hour dose of antibiotics, and we have not had a single infection during this period. So these included patients who were diabetics and who had rheumatoid arthritis. So I don't think we need to really change our protocol. Yeah, of course, if there is a undetected infection that just came up recently, or there is a ESBL kind of urinary tract infection, these are cases where we consider giving antibiotics for a more prolonged period of time. When it comes to revision scenario, I would like to divide them into if it is a aseptic revision, that is a non-infected revision, or if it is a infected revision. In my non-infected revisions, again I have followed the same protocol of just giving 24 hours of antibiotics. Whereas in our infected cases, of course, we have to follow it up for almost 4 to 6 weeks of intravenous plus oral antibiotics.
Sir, is this use of single shot antibiotic region specific or it can be used anywhere? Like we were talking about, is it patient specific or it goes out with all the patients? So similar question I have, that is it region specific or it can be used anywhere?
Well, if you're looking at the geographical region wise, I mean, I've had a lot of surgeons asking me that whether is India a right country where you can just give 1 dose of antibiotics? Mentioning that our overall atmosphere is so contaminated and polluted. It does not work like that, because when you're performing a knee replacement, you're not performing it out there on the streets. You're performing it in the operation room, in the operating theater, and that has to be clean. Whether it is the Western world, whether it's India, or whether it's another country. So it's definitely not region specific. If you are going to have a contaminated OT, then you are going to have an infection no matter you give 1 day of antibiotics, 5 days of antibiotics, or 15 days of antibiotics. So definitely not region specific.
Sir, you have a huge experience in joint replacements, basically the knee replacements. So there are post-operative analgesias, and out of the two methods, that is the local cocktail filtration and epidural anesthesia, which method do you prefer the most?
I preferably am still going with epidural analgesia for my bilateral knees. That is when I'm doing both my knees in the same sitting. And for my single knees, I've started alternating between something called as a femoral block, where we just give an injection on the femoral nerve on the front part of your thigh, and the local infiltration, as has been asked. I have not found a great amount of difference as far as pain control is concerned with the local infiltration. But what the local infiltration has done is that it has brought down my drain, that is the blood loss after the surgery, to quite a significant extent. So that is that's a factor that is definitely advantageous to me. But as far as bilaterals are concerned, I still like to use epidural catheters. So there are centers that have started using local infiltration in both the knees in the same setting, and they have used drugs like propylene, which is said to be less toxic, so it can be used in both the knees simultaneously. But we have yet to get proper studies, international studies, as to the use of bilateral infiltration. Just as far as single knee is concerned, that is definitely a way to go by using local infiltration as a post-operative pain modality, because you can avoid using urinary catheters, you can avoid using drains, and you can get the patient to walk on the same day evening or the next day morning as soon as possible.
So we have thousands of new doctors coming up in India every year, and a lot of them opt in for being a specialist. So what message do you have to the upcoming doctors and specialists with respect to the infection and use of prolonged antibiotics?
Like I was just mentioning earlier, I mean, this is a very alarming situation as far as antibiotic resistance is concerned currently in our country, and we as specialists have to take cognizance of this alarming trend and start working at it at some point. And I think the best people would be the doctors who are passing out right now, who are getting into training. They need to understand the importance of this particular scenario of antibiotic resistance, and it's when they start practicing the good habits of rational antibiotic use, that's when we can go ahead and prevent it. So from my side, from our hospital side, Columbia Asia, we have tried to create and establish certain protocols, and which we are not just preaching to everyone, we are practicing it. It's part of our practice, using just a single day of antibiotics for major surgeries like knee replacement. So, and we have done it. We have done it over the last 1.5 years, and we have found that it does not make a difference to your infection rate. So, it is definitely now upon the other surgeons and who are performing surgeries which are which has got a lesser chance of infection, to take a short course of antibiotics rather than using 5 to 7 days of antibiotics. So definitely the take-home message today would be to be really careful with the kind of antibiotics that we need to use while performing simple surgeries. Sometimes if you're not implanting a metal and you're just doing a small nick and you're just draining, you're just taking a lump out, a soft tissue surgery, you don't need an antibiotic at all if the patient is healthy. For my trauma surgeries, I've just started using one single dose of antibiotic, and of course for my joint replacements we give about 24 hours of antibiotics. So like I said, we are not just preaching it out to everyone, we are practicing it, and hopefully with time you can also see the science behind it and sort of incorporate it and inculcate it in your practice, and that will go a long way in not for us, we have passed that generation, we have used those antibiotics for our benefits, but the next generation, that is by 2030, 2050, they would not be left with any antibiotics if we are not careful today.
So that was indeed a very good message for the upcoming doctors in India. If you change today, the healthcare scenario changes tomorrow.
Absolutely.
Sir, you are using Docplexus as a technology platform since quite long. What experience would you like to share with the doctors on Docplexus?
As far as Docplexus goes, I mean, it's not a specialty specific platform. That is the best part. So I get inputs not just about my specialty. We have inputs coming in from general practitioners. We have inputs coming in from people of other specialty like medicine, physician, gynecologists. So this is something that we routinely don't get to hear because we are usually interacting with people from our own field. So with Docplexus, we definitely can sort of interact, get feedbacks about what is happening in current scenario, if there is a current medical problem or social issue that is happening in relation with medical fraternity. There is always a very good healthy discussion about it going on in Docplexus, and that sorts of keeps me in touch with my fraternity. Even though I am physically not able to reach out or contact many people, with Docplexus what I get to do is online we are constantly in touch, we are sharing views, important issues are discussed about, there is a platform to put up my views about certain issues. So Docplexus as a platform for us doctors is definitely very helpful, and I found it to be very informative as well.
Sir, on behalf of Docplexus team, I would like to thank you for your valuable time and inputs. And we are sure that the information which you shared with us will be very informative to doctors on Docplexus.in also.
Thank you so much.
Sir.
Thank you so much.